In the previous video, we discussed how PAP therapy is the gold standard for medical treatment of adult sleep apnea. In this video, we will discuss surgical options for the treatment of sleep apnea in patients who cannot tolerate PAP therapy. Let's first discuss the indications for surgery in a patient with obstructive sleep apnea. Adults with sleep apnea should have a trial of PAP therapy before surgery is considered. In fact, most insurance companies will not reimburse for sleep apnea surgery unless the patient has tried and failed CPAP therapy for a few months. In addition, multiple studies have shown that nasal surgery does not improve AHI. So why do nasal surgery in sleep apnea patients at all? Nasal surgery can help to improve tolerability of PAP therapy and improve subjective symptoms. For example, a patient with a severely deviated septum who cannot tolerate a full face mask due to claustrophobia will likely be able to use nasal pillows after septoplasty. Rarely, you will see a patient with mild sleep apnea and very large tonsils. This is usually the only patient that can be quote-unquote cured with surgical management. Patients with moderate or severe sleep apnea should be explicitly counseled that while surgery often helps to reduce sleep apnea severity, complete resolution of apnea is unlikely. In fact, most studies that evaluate the efficacy of surgical therapy for sleep apnea use a success guideline of AHI reduced to less than 20 and a 50% reduction in total AHI. Remember, even a patient with an AHI of 16 still has moderate sleep apnea. Another consideration in the patient with obstructive apnea is that they often have increased operative risk. Patients with OSA have been shown to be more difficult to intubate, mainly because they can be retrognathic, have a large tongue, a short, thick neck, and decreased respiratory reserve. Patients with apnea have also been shown to be more sensitive to muscle relaxants and narcotics. They are at an increased risk of hypertension, which can manifest as difficulty controlling pressures in the operating room. This not only can make it more difficult for anesthesia management, but can lead to difficulty achieving hemostasis. Perioperative risks have led to several management controversies. Some physicians advocate for mandatory overnight observation in patients undergoing any oropharyngeal or multi-level apnea surgery. Narcotics are routinely used for post-operative pain control, but these are known to suppress respiratory drive. Care must be taken to avoid over-narcotizing patients with baseline apnea. Finally, post-operative CPAP use is controversial. Is it appropriate to restart CPAP after certain procedures, only with certain mask types, or only after a certain time period? Most studies evaluating the use of post-operative CPAP are in patients having non-upper airway surgeries, so these questions remain unanswered. Let's discuss nasal surgery. The three main nasal surgical procedures used in patients with sleep apnea are septoplasty, turbinate reduction, and sinus surgery. These three procedures are often done in combination with each other, depending on the indications present. This video will cover indications, risks, and benefits of these procedures, but will not cover specific surgical techniques. Septoplasty is indicated in patients with subjective nasal obstruction due to cartilaginous or bony septal deviation. The risks of septoplasty are pain, bleeding, infection, septal perforation, CSF leak, and saddle nose deformity. Septal perforation occurs when there is a through-and-through defect between the right and left nasal cavities. This can be avoided by ensuring that the mucoperichondrial flaps do not have opposing tears during dissection. CSF leak is a very rare complication that can occur if there is torque on the perpendicular plate of the ethmoid bone during surgery, which can cause a skull-base tear. This can be avoided by only using sharp cuts superiorly when resecting deviated cartilage and bone. Saddle nose deformity is a very rare complication caused by over-resection of the septum. If a sufficient caudal and superior strut is not present, the nose will collapse under its own weight over time. It is recommended that a minimum 1 centimeter strut is left superiorly and caudally to prevent this problem. Turbinate surgery is often combined with septoplasty to achieve the most patent nasal airway possible. Inferior turbinate reduction is indicated in patients with turbinate hypertrophy who have failed medical management, namely steroid or antihistamine nasal sprays. There are many ways to decrease turbinate size, including partial resection, submucosal resection, radiofrequency ablation, and coblation. There are pros and cons to each method. Risks associated with turbinate reduction are pain, bleeding, infection, and dryness due to over-resection. Finally, patients who have chronic sinusitis, either with or without nasal polyposis, can often improve their nasal PAP tolerability by having sinus surgery. This involves making larger openings into the 8 nasal sinuses and is indicated in symptomatic patients with a CT scan demonstrating chronic sinus obstruction. The risks of sinus surgery include pain, bleeding, infection, anosmia or loss of sense of smell, CSF leak, brain injury, and orbital injury, including blindness or double vision. Since the sinuses are adjacent to the eye and brain, it is easy to see how lack of expertise or even difficult anatomy can lead to orbital and skull-base complications. The most common oropharyngeal procedure for sleep apnea is UPPP, which stands for uvulopalatopharyngoplasty. UPPP was first described for obstructive sleep apnea in 1981 by Fujita. Originally, the surgery involved removal of the tonsils and removal of the uvula with the surrounding soft palate tissue. Care was taken to bevel the incision so the nasopharyngeal mucosa was preserved, which could then be used to close the soft palate incision. Over time, analysis of UPPP's efficacy has shown that between 40 and 70% of patients demonstrate improvement in their AHI. Several surgeons have made modifications to the original technique to try to boost efficacy. Unfortunately, none of these modifications have drastically changed UPPP outcomes, most likely because it is important to address other areas of collapse, such as the hypopharynx, not just the soft palate. Risks associated with UPPP are pain, bleeding, infection, change in voice, and velopharyngeal insufficiency. The most serious of these is the risk of bleeding, since this can be life-threatening if immediate treatment is not obtained. Also, this procedure, just like tonsillectomy, is very painful. Other techniques to address the palate include laser-assisted uvuloplasty, somnoplasty, and pillar implants. In laser-assisted uvuloplasty, or LAUP, the uvula is removed. In somnoplasty, radiofrequency is used to ablate soft palate tissue. The pillar procedure involves placement of implants into the soft palate, which stiffen the palate via scar contracture. All of these are office-based procedures and are indicated mostly for snoring. Multiple studies about each show limited efficacy in their use for obstructive sleep apnea. In fact, LAUP is not approved by the American Academy of Sleep Medicine to treat obstructive sleep apnea. Another procedure historically used in the treatment of sleep apnea is genioglossus advancement. In this procedure, the genioglossus muscle is pulled anteriorly, which enlarges the space behind the tongue. Since the genioglossus attaches to the genial tubercle, the tubercle is freed from the surrounding bone via an osteotomy, followed by advancement of the bone anteriorly. There are a variety of ways to secure the bone once it is advanced, including rotating the bone so it cannot retract and use of a screw or mini plate to secure the bone. Risks of this procedure include pain, bleeding, infection, airway edema, numbness of the lower lip or chin, and midline teeth numbness or injury. There are other ways to advance the genioglossus, namely the Airvance procedure, which is a proprietary method of using a permanent suture, much like a hammock, to pull the tongue forward. Other procedures that involve the tongue are midline glossectomy and radiofrequency tongue ablation. In midline glossectomy, the midline portion of the tongue is removed. This can lead to severe edema in the postoperative period, even necessitating temporary tracheostomy. Newer techniques such as the use of a coblator, which does not heat up as much as cautery, laser, or transoral robotics can also be used. Radiofrequency ablation of the tongue, much like its use in the palate, is much more effective for snoring and has not been shown to significantly decrease AHI. There are two other areas in the hypopharynx that have been targeted with sleep apnea surgery. First, partial removal of the epiglottis can be performed in patients with an omega-shaped epiglottis. Second, hyoid suspension procedures are used to attach the hyoid bone to either the thyroid cartilage or the mandible. This is thought to prevent collapse of the airway caused by excess mobility of the hyoid. The trouble with this procedure is that it is difficult to predict which patients will benefit from it, so it is often combined with other procedures in a multimodality approach. One of the newest surgeries being done for obstructive sleep apnea is implantation of a hypoglossal nerve stimulator. This surgery involves placement of an intrathoracic lead which senses respiration. When the patient is transitioning from expiration to inspiration, a signal is transmitted to a battery-powered generator that sits under the skin of the chest. This triggers an electrical impulse to a lead wrapped around the hypoglossal nerve. The nerve fires, contracting the associated tongue muscles. This occurs with each transition to inspiration, preventing collapse of the tongue. Preliminary results are promising. Patients who fail the above treatments and still cannot tolerate PAP therapy may be candidates for maxillomandibular advancement. This involves creating osteotomies of the maxilla and mandible and bringing the entire lower face forward with subsequent rigid fixation. This is the most effective craniofacial surgery in adults for treatment of obstructive sleep apnea, but it should be noted that this is an extensive procedure with prolonged recovery time. Also, MMA changes the facial appearance. Most MMA surgeries are performed by oral maxillofacial surgeons. Lastly, it is important to at least mention that tracheostomy surgery bypasses all upper airway obstructions and completely cures even the most severe of obstructive sleep apnea. Most patients, however, are not willing to tolerate the lifestyle changes that accompany the presence of a chronic tracheostomy. Patients with sleep apnea and morbid obesity can improve multiple medical comorbidities with bariatric surgery. While this is not specifically meant for treatment of obstructive sleep apnea, a common side effect of bariatric surgery is improvement in AHI. Surgery for obstructive sleep apnea has been around for less than 40 years. As the rate of obstructive sleep apnea increases with obesity rates and surgical innovation continues to improve upon the available techniques, it is likely that we will continue to identify more effective treatments with fewer side effects.